Good day to everyone. My name is Paul Wax. I'm the Executive Director of the American College of Medical Toxicology, and I'd like to welcome you all to our webinar series entitled The Medical and Public Health Considerations of COVID-19. Today we have a really interesting presentation about blood clots and thrombogenesis in the era of COVID-19, and that will be followed by an update from the front lines from Ethiopia. Next slide. I'd like to thank our webinar series partners for helping to promote this webinar series. Next slide. This webinar will be recorded and posted to the ACMT website in approximately 48 hours. All residents will get an email notification once this posting occurs. We also have been developing a series of webinar Q&As, which can be accessed at www.acmt.net/C19FAQ. And if you have any questions about the webinar series, feel free to contact us at info@acmt.net. Next slide. There will be a Q&A at the end of the webinar. Please type your questions into the Q&A box or the chat function on either the WebEx or the YouTube or Facebook Live chat functions, and we'll try to get to as many of the questions as we can at the end of the presentations. Next slide. I'd like to thank my co-moderator who will be helping out with the Q&A, Dr. Ziad Kazzi. He's a board member of the American College of Medical Toxicology and president of the Middle Eastern and North African Clinical Toxicology Association. Next slide. I'd like to welcome our guest moderator, Louise. Dr. Kao is a professor of clinical emergency medicine at the Indiana University School of Medicine in Indianapolis, Indiana. She's a member of the executive committee of the American College of Medical Toxicology and is a colleague of our featured speaker today, and Dr. Kao will provide that introduction. Thanks, Louise.
Good afternoon, everyone. I am honored to introduce our first speaker. Dr. Jeffrey Kline is the Vice Chair of Research and Professor of Emergency Medicine at Indiana University School of Medicine. He is also the Present Editor-in-Chief of Academic Emergency Medicine. He's a world-renowned expert in thrombosis. Today, Dr. Kline will discuss blood clots in the era of COVID-19, critically appraise the extent to which the current pandemic is a risk for thrombosis, and review potential anti-thrombotic strategies. Dr. Kline?
Control the slides here. I hope that everybody can hear me. I'm going to control the slides here, and this is my disclosure. I am going to mention something about some products made by these companies. I don't receive any personal funds. I'm not on any speakers bureau. I'm not a consultant for any of these firms, but my institution has received research funds for investigator-initiated work from these companies. So I think probably the little bit iconoclastic thing that I have to say, in case you want to listen to one thing and then jump off of this talk, is that I'm going to say that the COVID-19 disease is thrombogenic, but it's really not that special when it comes to being a clot generator. It's probably no different than pretty bad flu. A big part of it is what we're looking at in terms of surveillance. But I will spend a good bit of case just talking about biomarkers to look for activated coagulation and come to the conclusion that the D-dimer is really a great one-stop shop. I'll go through the mechanisms that develop immunothrombosis in SARS-CoV-2 and other infections, and name 4 or 5 mechanisms that are at play here and could come into how we block coagulation with this infection and other infections to come. One thing when it comes to dealing with the pleiotropic effect of heparin, remember heparin does more than just block thrombin, the action of antithrombin. Heparin is a large negatively charged molecule. I'm happy to be talking to a group of physicians and scientists who don't mind talking about molecules. Heparin's negatively charged and cytokines are positively charged. So there is a pleiotropic effect of heparin that helps cause protection of the lungs. And let's talk a little bit about how we might go about anticoagulation. I'm an emergency physician, so I'm going to talk about this primarily from the aspect of the emergency department. Just a reminder, H1N1 that was around a little over 12, 13 years ago, it caused clots. It was thrombogenic. Here's some work by Matthew Rondina out of Utah, just looking at platelet activation. The y-axis on these bar graphs are measurements of platelet activation and the expression of the fibrinogen receptor by PAC binding. And the far right bars in each of the graphs are H1N1 patients that were intensively monitored. So it's well known that many viruses and other infections have a connection to the immune system, activate coagulation. H1N1 definitely did. Perhaps one of the best known coagulogenic viruses is dengue. But H1N, or when COVID came out, caused a big splash. A lot of people really thought it was going to be a super clot generator. And I think part of it came from some of the early work. I want to emphasize a time-dependent change in how we've seen the thrombogenic potential of COVID-19. This was one of the first papers, came out of the Netherlands. This is Eric Clots. He's a pretty well-known researcher, a pretty good friend of mine, and he jumped out there, Eric did, and published this retrospective series out of intensive care patients in the Netherlands, and a third of them developed clots within 15 days of their ICU stay, and a lot of these had full-dose anticoagulation. There's another paper by Kiu et al., and people really got worried. Wow, this clots like crazy, and they're heparin resistant. That led to the development of some algorithms. This is one that I remember seeing back on April 9th from Mount Sinai, that's where the red arrow points. Recommendation of full-dose anticoagulation for intensive care monitored patients. And the same recommendation came out of the Indiana Department of Health. So I know of at least 2 large organizations that recommended it, and many others did. Full-dose anticoagulation for really sick COVID-19 patients. Didn't matter if you had clots or not. Just mattered if you were sick and had COVID-19, full-dose anticoag. Now, to think about this, you got to go back to second year med school. I think we need to spend a couple of hours on the clotting cascade. Nah, I'm just kidding. I'm an ER doc. I don't have enough attention span for that. But let me remind that there's a couple of components to hemostasis. One is just mechanical vasoconstriction. The other part is the marines, the cells that come in and plug the hole, mainly platelets, but also white cells that then help trigger the protein coagulation cascade, which is controlled by the traffic cops. You know, there's serpins. Most of these are serine protease inhibitors like antithrombin that come in there and regulate the speed of clotting. I won't spend much time on it, but just a quick overview of the clotting cascade. The part that probably matters to most people in emergency medicine is over here on the right. That's the tissue factor or tissue injury pathway that activates tissue factor, factor 7, which is actually circulating, made in the liver. And this is the first sort of explosive clot that helps plug the hole together with the platelets, followed by maintenance with the extrinsic or contact pathway. And that sort of comes in and regulates the clot and its strength. And is part of the reason why hemophiliacs tend to bleed in joints and not so much bleed out of their ears, because they just are not able to maintain the clot. And this contact pathway, of course, is activated by valves and catheters. And we're going to see coming down the pike some factor 11 inhibitors that are going to be cleared by the FDA in the next year or two. So they'll be helpful for patients with valves and catheters. Everything comes down here, activates prothrombin to thrombin, which clips off fibrinopeptides off of fibrinogen and then starts polymerization of fibrin. Every time you lay down a molecule of fibrin, in comes plasmin. As soon as the first molecules of fibrin start to polymerize, along comes plasminogen, gets converted to plasmin, and you start making D-dimer. D-dimer is, I want to say, the single go-to molecule to tell us about the thrombogenicity of this and pretty much any other virus that causes clots. It also correlates strongly with mortality in multiple studies, as shown by this forest plot on the left. This is a meta-analysis that's coming out in the journal, and I'll review it in the next month or so. And it just shows all of the papers that looked at D-dimers. And clearly, an elevated D-dimer increases the risk of death. And you can see it in this Kaplan-Meier survival curve that came out of a paper we published in Academic Emergency Medicine. And basically, if your D-dimer is twice the normal threshold, in this case 1 milligram per liter, that's the same as 1,000 nanograms per ml. Higher than that, the survival curve looks worse. So the dimer is a good connection. And of course, it's what we're using to monitor clots. And I think you'll see in non-COVID setting that we're going to go to a D-dimer-based monitoring system, not just, you know, well, 3 months or 6 months of anticoag for DVT or PE respectively, or a lifetime based on certain algorithms. We're going to treat till your D-dimer is normal and monitor your D-dimer. You'll see this becoming more and more of a standard of care of how we take care of all clots, but it's a great biomarker for looking at the severity of dimer, of coagulation in COVID-19. Quick reminder, there's the problem of FEUs versus D-dimer units, and this slide just reminds us that it takes 2 fibrinogens to make 1 D-dimer. Fibrinogens are then polymerized by factor 13 that link the D domains. You can't make a D-dimer in a cell or in a bacteria, so there's really no way to get a monoclonal D-dimer. You have to immunofiltrate it at the affinity purified. It's part of the reason that there's a messed up standard or threshold among various D-dimer manufacturers. And also, some of them use FEUs and some of them use D-dimer units. You know, this group may be familiar with this, but the FEUs are the classic cutoff is 500 nanograms per ml. And the D-dimer units is somewhere around 250. The most common machine, the Hemocil, uses an oddball number like 243 or 238 D-dimer units. You ever get mixed up and you can't remember which is which? The way I like to teach it is the word fibrinogen is bigger than the word D-dimer. So fibrinogen units are bigger than D-dimer units. There. How's that for some teaching? So let's go through a couple of things that SARS-CoV-2 infection can do to cause thrombophilia. But first, let's look at a regular old pulmonary embolism clot here. A is a trichrome stain that just shows that, you know, there's a bunch of stuff inside of clots. But if you immunohistochemistry stain with the blue specifically looking for platelets and the tan looking for monocytes and the white looking for neutrophils, clots are complex organisms. I mean, they have red cells, platelets, white cells, all kinds of protein in them. And these cells contribute to the fibrinolytic resistance of clots. The more cells that are in there, the harder it is for plasmin to cleave the fibrin structure. There's platelet activation that's part of clots, immunothrombosis that leads to this concept of NETosis that I want to show some pictures of. Hypoxemia itself is thrombogenic just by stabilizing the transcription factor HIF, hypoxic-induced factor. HIF then upregulates multiple things that cause clotting, including plasminogen activator inhibitor from the liver, which inhibits fibrinolysis. So hypoxemia itself is thrombogenic. And then there's the nephritis causing antithrombin leak that promotes heparin resistance in COVID-19. And here's a pictorial reminder of the complexity of SARS-CoV-2 infection affecting the lungs. Multiple blood cells causing apoptosis down here in the lower middle of the screen. You'll see a PMN, a neutrophil that's undergoing apoptosis and releasing all of its guts. Those guts being neutrophil or being its nucleus as well as its granulocytes. The nucleus then will bind to clots and form a network around them. Over here on the top right, you can see the protein coagulation pathway activated, ultimately leading to fibrin. And look at this clot. I think this kind of reminds us of the complexity of clots. They're coated by activated platelets that here look like burrs or little starfish. That's what an activated platelet looks like. And surrounded by a network of DNA. And that DNA is very resistant to plasmin lysis. And that's what NETosis is about, is the network of nuclear material coming primarily from white cells on blood clots. And this is, in the last 10 years, has been a real hot area in thrombosis research, understanding how white cells make it difficult to break clots down, especially infectious clots. So here's a paper that I think has now been published in Blood, and this came from that Utah group that studied the H1N1 platelet activation that I showed at the start of the talk. And starting in the upper left-hand corner, here's a bar graph that shows that neutrophils have fewer granules, and the reason is because they've kind of undergone apoptosis. And this first 4 panels here, the top are healthy donors, and the bottom is from a COVID-19 patient. The right-hand 2 panels are stimulation with something called PMA that activates just about any cell that can be triggered. But even without activation, here in the lower left corner, you can see purple haze. That purple haze is free-floating, cell-free DNA floating around in the bloodstream of patients that are sick with COVID-19. And here's some aggregated data over on the right. The right-hand 2 bar graphs simply reaffirm this by showing the amount of cell-free DNA goes up in COVID-19 patients, and that there's myeloperoxidase, the right-hand bar graph, MPO DNA complex of myeloperoxidase is just one of those activators of the granules that are spit out by apoptotic neutrophils. So lots of apoptosis, a lot of cellular activity. It ends up getting deposited in the lung, lower left-hand 4 panels. The most important one I want to point to is on the left. You can see kind of a hexagon-shaped thing that's lit up. It looks kind of like a carnival here on the leftmost image, and there's a yellow arrow. What it's pointing to is multiple colors, and those multiple colors are cells that are trapped inside the capillaries of an alveolus of a lung, and they're labeled red for platelet factor 4, white for myeloperoxidase, green for citrullonated histone, and just regular happy nuclei are stained purple with DAPI. That's a standard immunohistochemistry stain. Lots of stuff gets deposited in the lung. These extracellular traps are contributing to ARDS and might be helped by anticoagulation. So here's some evidence of what's happening at the lung level. And there's plenty of platelet activation with COVID-19, and also just in patients that get clots. The work on the left is from my lab. Top 2 panels are healthy donors. Each bar shows cytosolic calcium concentrations measured with a fluorometric probe and put into a spectrophotometer. And, we like to stimulate platelets with multiple agonists, in this case, thrombin ADP and arachidonic acid going left to right, the basal measurement on the far left. And these are PE patients on the bottom 2 graphs. And what's the strongest activator of platelet cytosolic calcium, which is, by the way, the final common pathway that activates platelets? Well, it's thrombin. That's the second bar. And so platelets from PE patients are already activated, and platelets from COVID-19 patients are activated, as you can see in the right-hand side over here with the colored bars. And these are just showing the same basic phenomenon in any patient with COVID-19. So I'm making a case that, there does seem to be cellular activation and quite a milieu in severely sick COVID-19 patients that simulates the milieu of a PE patient. So they're ready to clot when they're sick. And that's an electron micrograph here of a platelet from a healthy donor on the top and a COVID-19 patient on the bottom. Most important image to look at over on the left, top versus bottom. You can see a bunch of holes in the platelet in the scanning electron micrograph on the bottom left-hand panel. And that just shows that this platelet has degranulated its alpha granules, and the alpha granules contain platelet factor 4. That's, of course, what you measure as a screening blood test looking for HIT, heparin-induced thrombocytopenia. And the banjo plot shows, or fiddle plot as they're called, shows there's a lot of platelet factor 4 in COVID-19 patients, as well as p-selectin expression in the far right-hand bar graph. So lots of platelet activation. So this leads to some trials that are ongoing. One is the use of a DNase or pulmozyme, which has cleared by the FDA for treatment of cystic fibrosis. And I'll predict, regardless of what happens with COVID-19 or with this particular trial, I think that you and I will be giving a DNase drug to patients with chronic pulmonary embolism, chronic clots, because it will be a congener that will help lysis either endogenously or something that we infuse. So I think this is something that isn't a waste of time for me to tell you about, that this is an evolving science, not just with COVID-19, but with the treatment of clots, and that is using a DNase to break that netosis to allow plasmin to do its job and reduce the resistance to lysis. How about platelet activation? One of the receptors that is connected to that cytosolic calcium is the angiotensin receptor. The angiotensin is elevated in COVID-19 and probably contributes to platelet activation. So there are two trials testing the efficacy of losartan both in outpatients and inpatients. Here is the NCT number from one of the two trials. They are both, one of the reasons I want to bring this study up, they are both being run by a man named Mike Puskarich out of Hennepin. And I'm very proud of Mike Puskarich because he's one of my former research fellows. So good job, Mike. Keep up those trials. They're both funded by the Bill and Melinda Gates Foundation, and I'm anxiously awaiting to see what Mike finds. And again, a reminder when it comes to heparin that we are dealing with an IL-6 hyper state when it comes to COVID-19. IL-6 in and of itself is thrombogenic. If you just infuse it in a rat, you'll have elevated fibrinogen levels, elevated pi levels, plasminogen activator inhibitor. And this is a generic slide on the right showing an invading organism, looks like bacteria, but this could be SARS-CoV-2 that itself just activates the immune system. And again, that pleiotropic effect of heparin probably antagonizes all of these cytokines, IL-6, IL-beta-1, as well as TNF-alpha, because cytokines are these oddball proteins that are positively charged that bind heparin, much like SDS, sodium didecyl sulfate, is used to bind proteins to move them electrophoretically. You can almost do the same thing with heparin. If you coat proteins, they become so negatively charged that they don't work very well. So there's a theoretical effect of heparin that has nothing to do with how it binds antithrombin to thrombin. It's catalytic effect that inhibits thrombin and causes anticoagulation. Just its effect on cytokines may be part of its therapeutic benefit. And that could be important because there's some pretty good evidence of antithrombin deficiency in very sick COVID patients. And let me say that that is not a unique thing. There are many sick, inflammatory, leaky capillary states, like even a sick post-op patient, where the kidney leaks antithrombin. And antithrombin is how heparin works. Heparin is a catalyst that gets antithrombin in configuration with thrombin, which then causes a chemical bond. Antithrombin is basically on a suicide mission. It's a SERPIN, a serine protease inhibitor, that wants to get into the active site of thrombin and kill it. Heparin helps that effect. But if you don't have antithrombin, then you're going to have at least partial heparin resistance. And that's the mechanism of how nephrotic syndrome causes clotting, is because they leak so much antithrombin, and why heparin doesn't work very well. Some of the older folks in the audience might remember giving plasma infusions to patients that had nephrotic syndrome before you gave them heparin to let the heparin work. That's not been done that I know of in COVID-19, but what has been done is to use direct antagonists of the clotting pathway just to bypass the need to inhibit, the need to have antithrombin, either with argatropan or dabigatran or one of the factor 10A antagonists. So when it comes to the biology, there's really clear evidence that COVID-19 produces a thrombophilic state, but what about the latest evidence, and what do we really know about using heparin? And so I'm going to say maybe not so much, because as we go, we're learning that this virus causes thrombogenesis, but it's not a super clotter. And here's some evidence coming out in academic emergency medicine, probably in the next couple of days. This is slated as the EIC POTM, my pick of the month from the journal. And this is work by Jonathan Freund out of France. And all I want you to do is look at this flow chart and go down to the bottom. And what you can see is that the prevalence of PE prior to COVID was 15%, and the prevalence of PE in all patients with COVID who underwent a CTPA was also 15%. So no increase. And, in France, they're pretty picky about how they do what they do a CT scan. And over here on the right is just a multivariate analysis done to adjust for the effect of COVID-19, and basically found that COVID-19 was not a risk factor for a positive CTPA scan in this French sample. This is a little iconoclastic, and we have an editorial by Chris Cabral accompanying this. And, there's always the question of whether the threshold at which doctors ordered the CTPA was different. And Dr. Cabral discusses that in his accompanying review. But in the issue of time, just want to let you know that there is a literature that is coming out again and again showing that maybe this virus is not so thrombogenic. And here's another multi-center study out of France that's really basically saying the same thing, although it's a different methodology. Bottom line with this slide, look at this flow diagram, lower right-hand side, that just says this. There's an 8% prevalence of CTPAs in another, not the one Jonathan did, another multi-center sample out of France. 8% prevalence of PE in a French sample undergoing scanning for PE is a very low number. Typically, French studies have prevalences of PE of 25, sometimes 30%. And just some circumstantial evidence that maybe not quite so much. It doesn't mean we have to go out of the gate and anticoagulate everybody that gets that has suspected SARS-CoV-2 infection. Here's a registry that I'm running across the United States, and this was an early analysis. We now have 11,700 completed forms and almost 20,000 that are uploaded. And one of the central questions we're asking is over here in this box. So these are the members of the Recover Registry over here on the left. You can't read them. I just want to put that up there to let you know, everybody, that this is 43 different investigators representing 150 hospitals across the United States. This is my own original work. And if you look at this interim analysis, the prevalence of any thrombosis in SARS-CoV-2 negative patients who were tested in the emergency department and followed for 30 days in this registry was 1.7% versus 2.7% in those that ended up with a positive test at any point in 30 days. Not a big risk ratio. Well, I've just looked at it again today, and this prevalence has gotten even weaker. It's gone from 1.5% in the SARS-CoV-2 negative to the 2.0% in those that were positive. And over time, that risk ratio has gone from about 3.0 to 1.3. So either our patients are changing or the virus is changing. The thrombogenicity seems to be weakening. And this is just something for emergency department patients is what are our predictors of a positive SARS-CoV-2 test? This is one of the key things I wanted to do in the registry, and this is after 9,500 patients. Some strong positive predictors: Black race, Latinx ethnicity, hypoxemia, or fever. No surprise there. Strong negative is the patient can say, I had no sick contacts. This is an amazing one. If you're a toxicologist, you might be interested in smoking. And it's not just me that found it. Smoking is a strong, I'm not going to say protector, but associated with a negative test, probably by the effect of nicotine on the ACE2 receptor. It downregulates it. Also, using anticoagulants at the time you were tested was protective, but weirdly not as protective as was smoking. This is almost just an off-target, just sort of fun slide for folks to know about. What about clinical practice guidelines? The CHEST group put together a systematic review of all studies that looked at the prevalence of clotting in SARS-CoV-2 or COVID-19 patients. Starting at the top here, you'll see the Clots study and the CU paper I mentioned. The prevalence got less and less as the CHEST group looked at. This is work that has not yet been published, but is coming out in CHEST. And the bottom line from this clinical practice guidelines that propose to use rigorous methodology, the GRADE methodology, the most rigorous. They said, in critically ill patients with COVID-19, we recommend thromboprophylaxis over full-dose anticoagulation. So a little different than that slide that I showed you from the Mount Sinai group from back in April. These are some smart folks, and they were careful and really thought about it. They just said regular thromboprophylaxis for ICU patients, not full dose. What about sending patients home with COVID-19? Something that might be of relevance to those of you in the audience who practice emergency medicine. And so this is something that I wanted to address head on and say that one of the big goals is lung protection, because a big part of the ARDS is the precapillary pulmonary vasoocclusion that I've already mentioned. It's been known for years that ARDS has precapillary pulmonary vasoocclusion with an increase in alveolar dead space, shown by this Nuckton paper in New England Journal of 2002. We know that this is the natural pathophys of ARDS, but it's particularly nasty in COVID. So what we're really after in terms of thromboprophylaxis or anticoagulation is also lung protection to prevent the microvascular obstruction that you see again and again in reports and autopsy studies like this one I'm showing here. And the natural experiments, like the one done by Tang, and there were at least 5 others that followed. These are not randomized or controlled studies. They're natural history studies. And the patients that got heparin had lower mortalities than those that did not get heparin. And it seemed to be D-dimer dependent. The higher the D-dimer, the bigger the gap in mortality between the blue and the red bars for patients that had COVID-19, for those that were treated versus untreated with heparin. So that is a driving force for me in terms of making a recommendation, especially when that D-dimer gets out there above 5 times the local limit of abnormal. Now, I don't have a dollar's worth of evidence if a randomized controlled trial that's appropriately controlled and has an appropriate endpoint and is rigorously done is a dollar's worth of evidence. I only got 25 cents worth of evidence, and that's what I'm going to draw from Mariner. And Mariner is a large randomized trial that looked at patients pre-COVID-19 who were at risk of clotting based on this thing called an improved score. And they were patients that were recently discharged from the hospital. And the question was, they had an elevated D-dimer and a score greater than 2 on this box. Would they benefit from 10 milligrams of rivaroxaban for 45 days? And it was double-blind, randomized, rigorously done, Riva versus placebo, and a clear reduction in major thromboembolic events without an increase in bleeding risk. So this was before COVID-19. Now, there are embargoed data that are coming out that are going to address a Mariner-like study in COVID-19, and I think it's going to support what I'm going to recommend. And that also comes from a work that my group did that is also in review, not published. This is hot off the press. This isn't even on the press yet. This is preprint. And this is a study I call Math VTE, and this was 1,421 patients with PE or DVT. 518 of them had PE. They were low risk by Hestia or SPESI, if you know anything about risk stratification studies for PE, and they all got either Riva or apixaban. And the point that I want to make that's relevant to this COVID talk about maybe treating patients with COVID-19 that are going to go home out of your emergency department is the bleeding risk in this study was extremely low. These were patients with macro clots that we diagnosed. They didn't have COVID-19. The rate of bleeding was 12 out of 1421 with upper limit confidence intervals below 2%. So this basically helps reinforce, this is another kind of 10 cents worth of evidence to say, look, the bleeding risk is low if you appropriately select patients and give them Riva or apixaban. They can go home and they're not going to bleed severely. By the way, out of these 12 bleeds, these were just bleeding that led to rehospitalization. Only 1 out of 1,421 was an ISTH severe bleed. That was one patient with menorrhagia who required a blood transfusion. Nobody died. Nobody had an intracranial bleed. Nobody had surgery. Nobody had decompressive surgery. Bleeding rate is extremely low. That's going to be part of my final slide. I just have 2 more. And the one thing I want to challenge us on is that I think that the venous ultrasound is an extremely valuable test. If you get good at it, it's a fairly easy exam. Even in obese patients, you can do it fast and you can bill for it. And it's something that I use every day on every shift that I work. And I find it to be one of the most valuable ultrasound exams that I can do on a daily basis. And I think we should recognize that an emergency physician, you don't have to necessarily be an emergency physician. I'll say a bedside, appropriately trained physician. You could be an internal medicine physician, a critical care physician, can do these at the bedside. And if it's positive, we need to give full dose heparin. If it's negative, it argues in favor of just thromboprophylactic dose heparin, which we should be doing right away in the emergency department. So I'm going to end my talk on this slide, putting everything together on some reasonable and prudent, but not necessarily standard of care recommendations for COVID positive patients in the emergency department. The first thing I want to say is consistent with the CHEST guidelines. If you have a patient you're admitting to the hospital, ICU, floor, wherever, and you strongly suspect SARS-CoV-2 based on some of those criteria that I gave already or using CDC criteria, go ahead and give them a dose of enoxaparin right there. Boom, 40 milligrams. Don't wait for the hospitals. Don't wait for the orders. Don't wait for them to get a bed. Just give it right now. You can benefit. Give them some lung protection. That's pretty clear. I'm going to go out and say if you have known COVID-19, or you just have an overwhelming story, like they have loss of taste and smell and a first-degree family member with the disease and other symptoms, and a dimer greater than 5 times, I am full-dose anticoagulating with enoxaparin. The bleed rate is extremely low. In our registry, we're seeing almost zero bleeding related to COVID-19. It might cause DIC in some patients, but it's not causing bleeding. So that's the second recommendation. The third is everybody that has COVID positive that you are admitting should get at least a bilateral lower extremity ultrasound on admission. And if it's positive, full dose anticoag. If it's negative, that supports just thromboprophylactic dose. Maybe the same thing should be said for strongly suspected or COVID positive that you're sending home as well. But I won't say that's a reasonable and prudent thing. I think it's really good care. Again, these are not standard of care recommendations. These are, based on the evidence that we have. And then the last thing I'm going to say is if you have a COVID positive patient or one that's strongly positive based on pretest probability criteria, I think you should consider giving 30 days worth of rivaroxaban. And I say 30 days because everybody can get a 30-day card for free. It doesn't necessarily have to be Riva. Apixaban, in my opinion, is at equipoise and works just as well as Riva. The dose for Pix that I would use would be 5 milligrams per day. And again, that's based on piecing together Mariner together with MATH VTE and acknowledging that there are embargoed data from a randomized trial that are going to be published soon involving COVID-19. So that ends my portion of the talk, and I think at this point we will take it up probably with questions, and I don't know if they're done over chat or some other way, but I may turn it back to Louise or one of the other organizers, possibly Paul, and see how we're going to go about doing questions.
Dr. Wax, would you like to start with the Q&A?
Sure. Thank you very much, and thanks to a great talk from Dr. Kline. So a number of questions in the box. The first one is, what COVID-19 strain identified to cause the clotting? Are we identifying specific COVID-19 strains in this study? So, do you have any data about the difference in the genetic typing of the COVID-19 and whether there's any variation with the clotting propensity?
These complex maps that show us the mutation of the genetic code and then link it to the prevalence of clotting. The only thing that I've seen is plots of geography and time, but I've not seen anything yet linked to clots. And you can be sure it's coming, but it's not something that I personally am working on or I know anyone that's working on. But it's a great question, and it's a great question that I'm sure will be answered with time.
Okay, great. Thank you. So the next question is about COVID-19 thromboprophylaxis. Is there any superiority or inferiority of low-dose aspirin versus low molecular weight heparin?
All right. Unfortunately, I don't have any knowledge of an antiplatelet trial being done against an protein thrombotic trial. So I can't answer in COVID-19. In other states, heparin tends to win out. Even the orthopedic surgeons have caved in and decided that it's better to not use aspirin and to use 40 milligrams of enoxaparin or one of the low dose anti-10A oral regimens. So I don't have any direct evidence of an anti-thrombotic agent. If I may, since I can speculate because nobody has any evidence, so we can all say what we want. If I had to pick a small molecule to inhibit platelet activation in this disease, it would be Viraxapar. That's an FDA-cleared drug that is a PAR, a platelet or a protease-activated receptor antagonist. That's the receptor that thrombin binds to on the platelet. And remember me showing those plots that thrombin is the single biggest activator, and there is clearly thrombin-generated potential with COVID-19. So Viraxapar would be what I think, like if I had to give my mother an antiplatelet agent, that would be the one I would want over aspirin.
Okay, great. Thank you. Another question is about how long does the D-dimer remain elevated, or perhaps at what rate does the D-dimer decrease? And specifically, this attendee described a case of a Hispanic gentleman who was 44 years old, and 28 days post onset of symptoms, whereas only symptoms had been quite mild. He still had a elevated D-dimer at 1.5 times normal. So what might be the significance of that, and what is the data about how long it stays elevated?
Well, the one thing I want to emphasize about D-dimer is it's not junk. This thing is not just there by accident. It's there because there are clots, period. It's incontrovertible. Clots are there and they're getting lysed. So this gentleman, if you did one of these fancy thrombin generating potential assays, would have an elevated TGP. It would be no doubt about it. I would say that individual, especially if he has no other reason for an elevated D-dimer, is someone that I would strongly suggest needs to be on low dose rivaroxaban, the 10 milligram dose. And so in terms of what is the decay, the decay rate of D-dimer after surgery, after childbirth, after multiple insults is fairly well known, and it tends to go down about a week after the symptoms or after the injury. But anecdotally, I'm seeing COVID have spikes that last or kind of come back again. And many people are wondering or fearing if this is some type of reinfection. I just don't know the answer. And I can give a good answer about childbirth. I can give a good answer about post-op. I can give a pretty solid answer about how long it takes after you get a dose of chemotherapy. But I really can't give one for COVID-19. It seems to be all over the place. Wish I could give a better answer.
Yeah, no, that sounds reasonable given what we know so far. So, next question: do you know if those with pre-diagnosed clotting disorders such as antiphospholipid syndrome are at higher risk for blood clotting compared to the general population in the setting of COVID-19?
All right. So what little I can say is the answer is no, but this is confounded as heck. Most of those people are already taking some kind of anticoagulant, so had some protective effect. That's about all I can say from the natural history of what we've seen so far. Okay,
great. And how about if a patient's allergic to heparin? You have any recommendations for that group?
Wow. Well, if they're really sick and they can't take an oral medicine, if they could take an oral medicine a direct 10A or even dabigatran. I think a direct 10A is a little better, a little bit lower risk. A direct 10A is the best option, but if not that, then it's got to be argatroban, which is very expensive and kind of arduous to infuse. It's constant infusion, requires a lot of monitoring. So that would be my recommendation. If they can take orals, then Riva or apixaban.
Okay, great. Thank you. I'm going to turn it back over to Dr. Kazzi for some additional questions.
Thank you, Dr. Wax. Dr. Kline, that was an excellent presentation. I think I particularly enjoyed the details and the molecular mechanisms. Thank you. Regarding the, I typed in that question in the chat box during your presentation. So is the D-dimer prognostic in COVID-19 patients that for some reason, if you do an ultrasound or you do a CTPE and they don't have any, radiographic diagnosis of PE or ultrasound, is it still prognostic?
Yes, absolutely. And the reason that everyone, including me, believes it's prognostic is that precapillary pulmonary vasoocclusion that leads to the high compliance ARDS. So when we're talking about an anticoagulant effect, we have two things. One goal is lung protection, and the other one is preventing of macro clots that we can find with ultrasound and CT scan. So, even in the absence of being able to find clots on ultrasound or CT, there's still a benefit to full dose anticoagulation in a patient with 5 times upper limit normal of D-dimer solely for the sake of the lung.
It's pretty fascinating. I personally cared for a patient a few days ago who had the similar dilemma where the patient had chest pain, shortness of breath, and there was concern of COVID-19. The rapid PCR was negative. Of course, I was going to repeat it, but the first one was negative, and the D-dimer was in the 5,000. And so I decided to get a CTPE on him, and there was no PE, but there were some infiltrates, some non-specific infiltrates on the CT scan, not seen on the chest X-ray. It made me think of also, when we are getting these patients in the ED, and that's my question to you, people that have chest pain, let's say, and they don't look like they have COVID. They just have chest pain and maybe no fever, of course, no shortness of breath. And say you pursue a PE protocol on them or a D-dimer, to get a D-dimer just to screen them. And the D-dimer comes back at 5,000. And then, you do a PE protocol and it's negative. Should you now test them for COVID? Because, if you were not going to test them initially?
I think the answer is absolutely yes. 5,000, assuming a normal cutoff of 500, is an extraordinarily high D-dimer. I mean, I look at databases of thousands and thousands of D-dimer measurements, just in my sort of career as a researcher. So, like when you see a number like that, that is very concerning. There's something really bad happening there, and that needs investigation. Not just shrug your shoulders and say, "Oh, the D-dimer's elevated by everything. That's the patient having a bad day, or the patient's in a bad mood." No, there's something happening with that 5,000, and at the very least, do a COVID, a COVID screen, a SARS-CoV-2 test, and lower extremity venous ultrasound would be my next step. 5,000, there's clot somewhere.
Well, that's important, I think, for healthcare providers to learn about this from people that are experts in this, like yourself, about the elevation in the dimer and its prognostic value. I had a woman who was postpartum. She was 2 weeks postpartum, came in with Bell's palsy, and had an elevated dimer, and no respiratory symptoms at all. Should she be tested for COVID?
How did she end up getting a D-dimer?
It was done by, I don't know, it ended up being done in triage.
Oh, my God. First thing I would want to do is find somebody to yell at them a little bit. That would make me feel a little better. Then after that, and feeling bad about yelling at the person, I would have to go back and look at things. The connection between a Bell's palsy and an elevated D-dimer, I don't know of any. I can't come up with any intuitive. But in today's day and age, I would say yes. I would say, what what else is circulating in the environment that would cause this? What would I do with this? Again, maybe put her on anticoag for 30 days if I thought she was. And by the way, one of the things I should have said clearly is when I'm considering, or what I think experts would recommend, not just myself, but other writers on the CHEST guidelines, if you're sending a patient home with COVID-19, not everyone needs to be on Riva or Apixaban. Those that are going to be sick enough for a couple days of bed rest, 2 days of bed rest, because they get immobilization. I'm really sorry. I've got 2 nieces that are going to come in the room, and there's just nothing I can do about it. Hi, sweetheart. There's just nothing I can do to control it. Sorry. I'm moving.
That's okay. Yeah. Understand.
Yeah. Okay. There. So we were talking about D-dimer and a Bell's palsy, kind of a unexpected, just out of the blue. Didn't expect this test to be ordered in today's setting, and you know, I honestly don't have enough information to have any idea exactly how often that is happening in patients that are asymptomatic from COVID, have some other just ancillary complaint, and somehow we stumble into their D-dimer diagnosis, to their COVID diagnosis through D-dimer. I've not heard of it, I've not seen it, and if they're not particularly sick and they're not going to have bed rest, I'm not sure I'm going to act on it. Again, I'm going to be really concerned if there's a 5,000 number, because that's not 590. That's a totally different, area. Fewer than, 3 or 4% of all D-dimer assays are up in that high of a range, and very many of them end up with a diagnosis of clots in the next 45 to 90 days.
Sounds like an area of study in asymptomatic COVID-19 patients to look at their dimers and see whether it's elevated. Another question came through regarding the discharge meds, the oral anticoagulants that people are getting when they go home. For example, if they happen to be on warfarin, for example, would you switch them? Let's say they're therapeutic on warfarin, they've been on warfarin for some other reason. Would you switch them to another medication? If they're outpatient or inpatient, would you switch them to heparin? And would you also consider in the outpatient management of those who have occupations that are potentially involved trauma? Would you maybe modify your recommendations? So those are 2 questions.
Yeah, so I think the first one, I actually saw it come across, and it did specifically say if the INR is therapeutic, I wouldn't touch it. I would just leave them on warfarin. We're not going to get a better anti-thrombotic effect from a small molecule, direct antagonist like Riva or a Pix. So I wouldn't change the warfarin. And then the other question is about trauma. What was the?
Well, occupational consideration. So someone's occupation has trauma.
Well, there's always room for judgment. And when we look at the math VTE data, where we did this in 1,421 patients who about somewhere around 80 to 85% of them identified themselves as not retired and working. So, somewhere in there's somebody that has some trauma risk. We didn't specifically do anything except, say, use clinician judgment. And for what it's worth, with that sample, we had an extraordinarily low bleed rate. If you have someone that is, let's say they're a ranch hand, or they just insist on riding horses, or they do something that is one of these high-risk activities, if they need to be on an anticoagulant, the safest thing they can be on is Riva or Apixaban, by far safer than warfarin. Now, if we're talking about sort of thromboprophylaxis against COVID, where we're not doing standard of care, we're doing reasonable and prudent, what's the best thing I can do for my patient? Well, then you just got to get into your own clinical judgment. If you really think this person is going to be at risk, and if they're well enough to go get themselves in a traumatic situation, they probably don't need to be on it. I'm really talking about the COVIDs that we're sending home that we think are pretty sick. They're sick as they got the influenza. They're going to be in bed for 2 days. And that's probably not a person that's going to go out and bang his or her head.
Agree. And again, Dr. Kline, thank you so much for all the research you've done in this area. It's really groundbreaking research that changes our practice. I think now I'm going to turn it over to Dr. Wax to close the webinar. Dr. Wax?
Well, thank you. Again, thanks so much, Dr. Kline, for a really superb presentation. Sorry to those who were looking forward to the presentation from Ethiopia. There must have been some web-based issues there, and we'll try to invite her back for a future webinar. Next slide. So again, this webinar today was recorded and will be posted to our website, and we'll send an email announcement about that by Friday. If you have any questions, feel free to contact us at the info@acmt.net. Next slide. The webinar series will continue in 2 weeks on September 16th, 2020 at 3 p.m. Eastern, and this is going to be a very important webinar on vaccine safety. Dr. Nera, who's Director of the Division of Epidemiology from the Office of Biostatistics, will be talking about vaccine safety as we prepare for a COVID-19 vaccine to be released sometime in the next number of months. And this will be followed by a presentation from Dr. Sheplovich from Tel Aviv, Israel, who recently released some of his research looking back at vaccine safety post-marketing with many of the more recent vaccines over the last 10 years. So this will be in 2 weeks from today, September 16th at 3 p.m. Eastern. Next slide. And all of our previous webinars can be also accessed through our prospectus, which is up on our website, as well as announcements regarding forthcoming webinars. Starting in October, we're going to be moving this to every 2 weeks and plan to continue this webinar series for the foreseeable future. Thank you very much and have a good day.